Welcome. I'm Glenn Anderson with the Olympia Fellowship of Reconciliation. This TV series explores a variety of issues that relate to peace, social justice, and nonviolent social change. Everybody talks about healthcare reform, but mainstream politicians and mainstream news media keep avoiding an obvious solution: a universal, single-payer system like other industrialized countries have. The United States is virtually alone among them in treating healthcare as if it were a commodity to be manipulated by private insurance companies and other wealthy and undemocratic forces. Other industrialized nations recognize healthcare as a human right that should be protected by government and that should be operated for the people's well-being, not so much for private profit. During this program, you'll discover how practical, satisfying, and efficient a universal single-payer healthcare system can be. We have three well-informed guests who came to the studio to share their information and insights. I'm happy to welcome Robert Fithian. He's a retired physician, and he's an active member of the board of a statewide organization called Healthcare for All, Washington. He's done a lot of work developing and proposing legislative solutions to the healthcare funding crisis. Aaron Katz is on the faculty of the University of Washington School of Public Health. He was the director of the UW's Health Policy Program. He has provided analysis and policy development for the Washington Healthcare Commission. On this TV program, he's speaking as an individual, not for any public entity. And Larry Kalb is an active member of the board of a statewide organization, Healthcare for All, Washington. He does a lot of study and outreach to support the best ways to provide health care for the public. So welcome to all three of you. I'm glad you're here.
Good to see you, Len.
This will
Thanks
be
for having us.
Fun and informative both. In terms of serving the people who actually need health care, what health-related problems do you see in our current healthcare system? In what ways, in terms of healthcare, does our current system fall short?
Well, I would just say that the system that we have doesn't provide an environment in which physicians and nurses and other providers can provide the best care. It puts barriers in the way of individuals getting the care that they need, and that's really just a start.
Well, it's unduly complex and complicated, Glenn. That's very frustrating, and in addition, it's very expensive. We say it's unsustainable, and I think most systems analysts would say the same kind of thing about any Rube Goldberg system like this is.
Mm-hmm. We have a lot of people who don't have any health coverage at all. I've seen various numbers, 45 million Americans, 46 million Americans. I've heard most recently. I saw a thing lately that says during a 6-month period or more during 2002 and 2003, there were 1.6 million Washingtonians who had no coverage at some point during that time. A lot of people had inadequate coverage. I also saw a figure that says more than 18,000 Americans die every year because they don't have health coverage. And this has got to be, the system that we have is causing health problems. It's not just an economic thing.
Well, it's always a debate about how you define the number of uninsured people at any given time in any given place. But for the past decade in the state of Washington, 600,000 people have been uninsured completely during that period of time. And it's been a pretty stable number in spite of a lot of incremental attempts to extend coverage to these people. It hasn't moved anyplace.
You know, it used to be a number of years ago when people would say, well, there's lots of uninsured people. The response from many people was, well, yeah, they're uninsured, but they can get care. I mean, they go to the emergency room, they'll find some doctor. But there's actually been some very good research in the last 3 or 4 years that documents that, in fact, being uninsured is bad for your health.
Well, and then a lot of people end up not being able to get the coverage or a procedure they need or something because their insurance company won't allow it. And there are all kinds of barriers, as you mentioned. There are economic, financial, cost-related problems. What are you seeing in the financial side of things in terms of problems with the current system?
Well, one thing is that medical inflation is double-digit in the face of wages increasing at 3 to 4% a year, and healthcare triple or quadruple that.
Well, the other thing that you want to take in consideration too is if you got someone who's working a part-time job, that part-time job is not going to offer health care benefits. If you have someone who's working at $7.50 an hour or $8 an hour, that takes up 100% of their wages just to pay for their family's health care insurance. That right there, they can't sustain that. I mean, they can't lead a productive life and then pay 100% of their wages on health care alone.
You know, the reality is that the system we have is too expensive for everybody. If you were to look at business budgets, family budgets, state budgets, the federal budget, in all of those cases, the cost of health care is eating up a larger and larger part of the pie, which means something else gets left behind or gets short shrift. In the case of this state, for the last 15 years, it's especially been education that we have a hard time funding.
Well, even if it were more expensive, lots of Americans would be willing to spend that if they got the value out of it. But our health system does not give as good results as 37 other countries in the world. So we don't get our value for the money we pay.
Yeah, I saw the reference in some of the research I did for this that, who's it, World Health Organization that rated the quality, and we were 37th out of that. The complexity of this, so much of our healthcare dollars being eaten up by the claims process, administering the insurance policies and filing for claims and being denied and resubmitting claim forms and stuff. It sounds like a Rube Goldberg thing, and for some people may not remember Rube Goldberg, who developed these wonderful cartoons some decades ago, and he would always come up with some elaborate system to do a simple thing. This is how he develops a way to sharpen pencils, and it starts with you open a window and you fly a kite out the window, and the kite is hooked onto a little pulley, and the pulley is attached to the ceiling, and it opens the door to a little like a little glass container, and the moths escape from this glass container. The moths come over and they eat the flannel shirt, the wool shirt here. And as the weight of the shirt becomes lighter because it's being eaten by the moths, it starts to ride up a little higher. It goes through the pulley it's attached to on the chair, on the ceiling, and a shoe drops down, and you can see the shoe then trips a switch that's attached to a wall, an electric switch, that turns on the electric iron that you see on the ironing board down below. The ironing board burns a hole in some pants, or the electric iron, burns a hole on the pants that are on the ironing board, and the smoke from the burning pants goes into the hole in the tree, and it smokes out the possum that's in the tree, and the possum jumps into this basket. And when it jumps into the basket, the basket drops down, pulls on the rope, and the rope lifts up the cage that allows the woodpecker that was underneath the cage to start pecking on the pencil. And the pencil is the last thing you have on the end over here. And as a fallback position, there is a knife, an emergency knife that's handy in case either the possum or the woodpecker gets sick and can't work.
And that's the emergency room in our system of Rube Goldberg
Yes.
Coverage.
That's right.
As Aaron pointed out as we were preparing for this production tonight, the process here, instead of a kite, starts with putting your insurance card on the scanner, from where it goes down 27 different chutes depending on which plan you're covered on or not covered on, and it starts a series of events like this.
Right, and all kinds of processes of saying, can I get this test that I need? No, you can't because you're in the wrong plan. Well, the doctor could resubmit it as something else, and it does mimic that, and your emergency room fallback is great.
But I would say that this picture, the Rube Goldberg picture of the system, it really only looks like that from the point of view of the patient or the care provider. But if you turn that about 90 degrees, you would see a system that's perfectly designed to generate income.
For whom?
For whom? For everybody. All $2 trillion of the money that we consume every year in healthcare in this country goes into somebody's pocket, which includes all the care providers, doctors, nurses, clinics, hospitals, insurance companies, pharmaceutical companies, medical device manufacturers, researchers, et cetera. I mean, we have to remember that that's all income for somebody. So this system is actually perfectly designed to provide those incomes.
And to bring out the importance of this, in the state of Washington, that amount of money each year comes to $40 billion a year. And anybody that can collect a large portion of that up front makes a lot of money on the money, regardless of the system.
You're talking about the insurance companies that collect the premiums, and they invest it, and they're making a profit from that.
Yes, that's where the business is. And insurance is a valid business, but it doesn't belong in this particular setting.
Right. And the dollars that you talked about, many of those dollars aren't going to provide health care services. They're doing all the overhead, the administrative.
Right, and actually this system is a perfect portrayal of all the middlemen who are involved there, because what they're trying to do is not only cherry pick who they're going to give care to, but they're trying to avoid all the risk that they can. And this cartoon actually portrays the very basis of business, because they're in the business to make more business. And so each one of these middlemen, of course, are making more and more business. And of course, when we come right down to it at the end, like what you just said, we're not getting any care for that. But if we took that money and we took these middlemen out of the system, then businesses, families would have stable budgets. And basically that's what we want. And we also, at the end of the day, we want better care. We want quality care.
You had a chart in a PowerPoint presentation that you've done showing over the last 32 years.
Right. And actually,
if you can describe what that is, we don't have a copy of it here, but if you can describe how that graph looks.
Exactly. The graph shows the year 1969 to 2003, I believe it was. And there has been a 2,500% increase, 2,500% increase in amount of administrators in all sectors of the medical insurance industry.
So that's like 25 times.
Exactly. And the amount of physicians, healthcare professionals over the same amount of time has increased only 149%.
Yeah. So I saw the chart, and the medical professionals, the graph went up slightly, and the administrators, the people, the paper pushing bureaucrats with the insurance companies and all that stuff, it just went up like this. It was amazing.
And you can equate the amount of administrators, the bureaucracy that we have in our system now, to all the profit is going outside of the system so that we don't get the care that we need.
Aaron, can you describe the concept of risk pool?
Well, in a risk pool is just the idea is a whole bunch of people who are pooled together, and that's the basis of insurance. Is you insure a group of people, or a basis, I should say, of insurance. You pool a group of people together, and from a social insurance angle, the idea is to have a pool that's large enough so that you have both healthy and sick people. So the healthy people subsidize the sick people. Of course, none of us know when we get sick or get hit by a bus.
Yeah.
So a lot of it is chance. And so a healthy risk pool is one which has both healthy and not so healthy people. And what we've seen in our system is the gradual erosion of those risk pools, or actually fragmentation, as businesses and insurance companies have attempted to figure out how just to pay for their own costs or the costs of their own small group of people, but not anybody else's costs.
So you don't want to be providing health coverage, health insurance for people who are likelier to get sick. You want to cherry pick, as one of you said, cherry pick the healthy people or something.
Yeah, we have a system that has very strong incentives, if we think of insurance companies, to avoid covering people who need care and to try to not pay for care that people need.
So if we were to think of solutions, of alternatives, what if we had, say, statewide throughout the state of Washington or throughout the state of Oregon, a statewide risk pool where everybody in the state, all Washingtonians,
We're in the same pool.
We're in the same pool.
That would be a very healthy risk pool.
Healthy in terms of
healthy in the sense that
economics
it's
of it.
sustainable financially. Because what happens when you have very small risk pools, and in one risk pool you have a lot of sort of people who have a lot of medical needs, is the costs of that go up for those individuals. And as the costs go up, the people who have the least medical problems get out, which means that the average cost in the pool now goes up again. And at some point, it's too expensive for the people to be covered. So if you had a risk pool across the whole state, with everybody in it, it would have that full range of medical needs and would be financially relatively stable.
Yeah.
And in the course of my practice life, which is quite long, in the 1970s, there was community rating for these kinds of prepayment plans. It worked more or less like that. And we did not see the kind of fragmentation and what's called stratification we see now.
Larry, when we were talking on the phone to prepare for the program, you were talking about what would be the characteristics or the criteria for a good healthcare system. If you were to design a healthcare system, what are the features you'd want to see in it?
Well, the first thing that I would do is have it as a right. And everyone would have access to guaranteed health care. So first thing off is everyone would have access to health care. It would be universal. That means that regardless of your age, your race, your gender, your employment,
status,
sex, and so forth, it would be universal. Access also means that it would cover pre-existing conditions. One thing that I would enjoy and promote in a new healthcare system is portability, which means that you can move anywhere in the state. You could change jobs, or if you get divorced or if you lose your job, you will always have health care. So it's continuous. It would never stop. So once you enroll into this program, it's a one-time operation. Once you're in, you're in. There is no eligibility rules. And two other factors. One is that it would be publicly financed and privately administered. And lastly, it would be comprehensive, which means it covers a whole slew of treatments, which we still have today if we had the proper care.
And the privately administered or privately
Delivered.
Means then that you get to choose your doctor. You don't. It's not like you
You
go
would
to the
have-
government doctor. You go to whatever doctor or other healthcare provider. And
Precisely.
it's
You would have a free choice of doctor. Yep,
Yeah.
that's right.
Yeah.
One thing to put this in perspective, Glenn, is that we already pay for everybody's needed care. Anybody can go to any hospital emergency room and get taken care of for their terminal illness or their heart attack or their fear of a heart attack. And they have to be taken care of by law. Our society is compassionate enough also to realize that we're not going to let people die and vomit on the street, or the opposite direction. So we are already paying for this one way or another, and it's called cost shifting. So
Yeah. So the issue then becomes: do we do this in a way that's efficient, or do we cause some people to go to the emergency room because they have no other alternative, which becomes very expensive? To use that as your primary.
this is the most expensive way
Yeah.
and the most
Yeah.
insecure way to do it.
So let's talk about what the basic concepts would be in a universal, single-payer, publicly funded proposal. And we've covered some of the things. I think of Medicare as something that, if you're of the right age and you're in the Social Security system, you're covered. And people like Medicare. People wouldn't. I don't know anybody who says, "Gee, I wish Medicare didn't exist." People who are covered think that's good. We just need more of it. So this is not a new concept that we're looking at.
No, I don't think it's a new concept at all. In fact, if you can look throughout our society and find institutions that are universal, publicly funded, and provide us with the security that we want. I think of the fire and police protection that we all enjoy. We don't question the fact that this is a government institution. We know inherently, this isn't talked about a lot, but we know inherently that if our neighbor doesn't have fire protection, we're in trouble. Or if our neighbor, if the cops are not going to come for an emergency at our neighbor's house, we're at risk. We know that inherently. We rely on government to do that. Yes, we would like it to work efficiently, for sure, but the main thing is universality and government accountability. So we have, and we can think of transportation systems, the roads, there are many, many institutions like that. So the notion of a universal system that is accountable to government, that's funded by government, is actually quite an integral part of American life.
And it's more efficient to have that one thing rather than to have to, if my house catches fire, call up 3 vendors, 3 competing fire stations, and say, how much would you charge to come over to put out the fire in my house? And they go, well, it all depends. Is it in the walls? Is it in the roof? Do you want, what, you don't want to have to do all that stuff, and you don't want to have to compete. You want to have one system. You just call 911 and that takes care of it.
You may not know this, Glenn, but we tried this in the late 1700s. In England and New England,
That's right.
people actually bought firebrands to get their proprietary fire department to come put their fire out rather than the neighbors. And that didn't work.
There must have been a few houses that burned down.
Yeah.
In the,
Well, they still
in the
sell
process.
those firebrands on Antique Roadshow. That's how I learned about it.
Okay. Well, the example that I've thought of is we in our society we've got the system of having free public libraries, and not every place had that, but we developed those pretty early on in our country. And if we didn't have the concept that you can just go down and borrow any book that you want to borrow, if we had instead had developed this library insurance where you have to buy a policy in advance and you have to figure out, well, okay, we got all these different competing library insurance companies. I have to figure out the plan that's right for me. How many hardbound books am I going to read in the next year, and how many paperbacks, and how many am I going to need? How long am I going to need them for? And what if I have a pre-existing research project that, you know, I mean, I'll have to pay a higher premium because the library insurance company knows I've got a pre-existing research project underway, and they know it's going to cost them more to meet my library needs, so they're going to charge me more for that. And it would just be, you know, and what happened? Oh, it would just be so expensive and complex that a lot of people wouldn't do it, and especially lower income people or people who have a hard time reading through the complexities of policies, you know. And if I lost my job, maybe I couldn't go to the library again. You know, I don't. It's screwy, but we don't do that.
I gather that human beings forever have lived by lots of myths, some of them pretty universal myths. But in the United States, there are a lot of supremacy myths that we believe in. And one of them is that choice is always better. Mm-hmm. But choosing the library insurance is not the choice you're trying to make. You're trying to choose a book.
Yeah,
it's
that's
not
right.
the library insurance that's a choice we want. It's the book that we want.
That's right, right. Yeah, we have to focus on what the real need is. And for healthcare, we need healthcare. I don't want to bog down with all this other stuff. So the simplicity, if we had the kind of system you're talking about, you have a card. Tell us how it might work.
Well, it's very simple, actually. What you would do is you would have a healthcare card. Whenever you wanted to go to your doctor of your choice, you would take your healthcare card with you and present it to the professional, the healthcare professional. He would take your card, he would swipe it through the computer system, and it would bring up where you live and if you're paid up subscriber to the program. And it would also bring up your medical history, which is very important in this respect because maybe some people don't know this, but in Business Week magazine in October 31st, 2005, they said that 195,000 people die every year because nurses and doctors can't read the scribbling that was presented on paper documents for each patient. So adverse events happen. Mm-hmm. So you take this card, your doctor examines you, and he says, well, you know, Larry, you need to have this type of prescription. And so he types into the computer to the nearest pharmacy. It says, prepare this for Larry Kalb. He'll be in to pick it up within the next 20 minutes. And so you go to the pharmacy. The pharmacist says, oh yeah, your doctor has emailed us and this is your prescription here. And by the way, there's no paper involved. So under the plan, you take the card, pharmacist swipes it and says, okay, you're paid up or you owe 19 cents or whatever it may be. But you just have one healthcare card that eliminates all of this administrative paperwork. And, you know, if we had an electronic claims payment system, it would save us 31% straight off the bat. So if we had a paperless system, you wouldn't even see a bill. So that's the best part of the whole system.
There'd also be a safety angle that suppose that doctor prescribes what you need, but there's some other prescription you have from a different doctor.
Exactly.
Or something. You go, wait a minute, these two have bad interactions.
Precisely.
If you take this with that.
Right, precisely.
They can catch that stuff. And now people, if you go to more than one doctor, you go to a specialist who might not know something.
Well, precisely. If you get an elderly person who doesn't know from 1 week to the next what the doctor has prescribed, and then they mix the two drugs, this adverse event could happen and may become a statistic in the end. So, yeah, it's the payoff is for patient safety.
Now, there's another angle that has the financial benefit there. If we had everybody in Washington State covered, for example, or everybody in the country, pharmaceutical companies have very high profits, and people in this country get charged a lot more than Canadians or people in other countries. We could negotiate negotiate prices and drive down the cost of prescriptions, right? I mean, there's no reason why we couldn't do that if we had a big enough risk pool, enough people. You've got some
The Veterans
bargaining power.
Administration does this now.
Yeah, and that silly thing that Bush put through with the prescription
Part D
plan, the
Medicare.
Part D, yeah. The Republicans explicitly prohibit the government from negotiating lower prices with the pharmaceutical companies, but we could produce that as a benefit of this system.
Well, another angle here too is the United States is the only country that directly markets medication or drugs through advertising. And Canada doesn't do that, for example. That's one of the reasons why their drugs are 50 to 90% cheaper, is direct-to-consumer advertising is illegal in other countries. But here, the pharmaceutical companies profit from it handsomely.
I don't know. I go to sleep when I watch the Lunesta butterfly, so I don't even need their prescription.
It sounds like we need to rethink our thinking in some fundamental ways in our society. One of the things that we keep running into in this country is we have this notion that the market is the solution, and that the private business is the way to do everything. In this case, insurance companies and so forth. And there are some things, like if healthcare really is a human right, if we think of that as a human right rather than something that's to be sold to the highest bidder, I mean, that would free us up to look at the kind of solutions we're looking at. You think of election campaigns as how a bad use of the market, where campaign finances deliver up politicians to be sold to the highest bidder. Whichever special interest wants to give the most to their campaign gets that politician's legislation.
Yeah, I think we have to, I agree with you, I think we have to change how we think about health and healthcare. I mean, thinking about it as rights is certainly appropriate. I think of it as collective responsibility, that like many things, the education of our kids or our physical safety in our neighborhoods, that these are collective responsibilities. We have responsibility and accountability to each other, and we elect legislators of one type or another to represent those collective interests. And it's not that the market doesn't have a place in healthcare. I think there are reasons to maintain market forces in some aspects of healthcare, but ultimately, healthcare is something that's basic to the American dream, to the life, liberty, and the pursuit of happiness. And like many other things that are basic, like education and physical safety, collectively we need to assure that people have the health care that they need so that they can be the best that they can be.
I don't think we've developed the words that resonate for everybody on this, but I look at this as the commonwealth of the society, the commonwealth. Everybody benefits from a good system like we're promoting. Everybody ought to contribute to it to the degree they are able, and everybody will be able to benefit by it. A colleague of mine developed the idea that it's like a pillar of infrastructure, like we use the transportation infrastructure of the freeway system to benefit everybody, and everybody pays their fair share to that. And I personally believe that access to health coverage is a basic pillar of infrastructure. It's a right, yes, but it also is a duty of the society to provide it.
And it's good for ourselves, like you were saying, if your neighbor's house is on fire and they don't have, the fire department won't come to them because they're not in that plan or something, that puts your house at risk.
Yeah, the greatest threat as far as bioterrorism or pandemic flu or bird flu, one of the greatest threats in our society is 45 million uninsured people.
Yeah.
Because the sentinels for epidemics or infectious diseases are frontline healthcare workers.
Yeah.
That's where the symptoms are presented. And uninsured people don't go at the first signs of symptoms. So
Right.
having so many uninsured people is a huge threat if we're worried about epidemics.
So that it's possible to have some epidemic starting underway, and we don't know about it because the people are not
Exactly.
able to access our healthcare system. Yeah. So it's a matter of mutual safety, mutual well-being. You've talked about the need to reframe how we think about this. That's kind of what we're into now. Where's your thinking on that?
Well, it's to try to change the paradigm, the way we think about markets and what is and isn't a market force. I think it clearly is, healthcare is clearly not just a commodity. It's been around since Hammurabi in the 3000 BC. The health insurance system, the market system, has just been around in my lifetime. It started in 1933 when I was 6 years old and spent a time in South Bend in a company town and started to notice odd things about monopolies and employer-based housing at that time and water supply. It doesn't make sense that those are market-driven forces. The trust relationship between me and my healthcare professional is much more than a commodity. It's much more a trust relationship than it is a competitive relationship. And I believe we need to change that concept to one of the commonwealth and the common responsibility for society.
Larry, when we were preparing for the program, you were laying out some possibilities of what the benefits might be for big businesses, small businesses, self-employed people. Tell us, I mean, there are a lot of constituencies that would benefit.
Precisely. Under this new reformed healthcare system, employers wouldn't offer healthcare whatsoever. So in that mindset, what we would have are employers who would be able to have available capital monies so that they could hire employees, the ones that they wanted, instead of negotiating on health care benefits. One thing that employers would do would be able to have money available for advertising their products that they produce. They would be able to hire more employees. They would be able to put more money into plants and machinery that they need to make more products. They could train the employees that they have. They could retain the employees that they've had for years and years and years, which would produce a lot of loyalty to their company. And frankly, it would take out this discrimination of trying to figure out who is going to receive health care benefits or not. Because what we have right now are employees who may have dependents who are very, very ill, but the health care, the insurance company doesn't want to take on that dependent. So the employer says, well, we're sorry, Frank, but we can't insure your wife and kids because they're going to cost us too much money. Run up the bill for everybody else. We can't do that. So in a nutshell, businesses, well, here's another example. If you were interested in starting up your own business, if we had reformed health care, everybody would be eligible to access health care. So you could start your own business. You wouldn't have to rely on your spouse for health care benefits. So there's a whole level of the economy that doesn't exist here in the United States because we don't have the proper health care system.
Well, I know that nonprofit groups run into trouble. You get a small nonprofit, they just barely squeeze by on voluntary donations, and sometimes they can scrape together enough to hire staff, and then they feel lousy because they can't afford health benefits. And so here's some nonprofit organization that's trying to benefit the community or benefit the world, and they can't provide can't afford to provide health care benefits for their own underpaid staff.
Precisely.
Let me emphasize again the magnitude of this, Glenn. Major employers pay about 14 or 15% of their budgets to buy health care for their employees. That's greater than a prosperous company's profit margin. It's greater than General Motors' cost for steel. It's way disproportionate.
Yeah, and then it means, I've read that before about General Motors pays more for health care than they pay for steel. And what that does then is it runs up the cost of goods produced in this country, goods and services produced in this country, makes us less competitive, and we lose jobs to other countries because other countries can take care of their healthcare needs in more reasonable ways, and we have to finance our healthcare through the price of the products they sell.
And those Detroit companies are now getting their cars made in Ontario for that very reason.
Yeah. There's the saying that if you have this big intractable or this big problem that people sort of know is there, but they won't acknowledge it, it's referred to as an elephant in the living room. And it seems like regarding the healthcare crisis that all this big overhead, the administrative costs and the insurance company processes and all the time and staff time that doctors and healthcare providers spend trying to negotiate the payment process, that seems like the elephant in the living room in the America's healthcare crisis, and you just don't hear it talked about when politicians or the media talk about what to do about healthcare.
Well, I guess my view of administrative spending or costs in the system is it's really a symptom of the problem. It's not the problem. Yes, it represents a lot of money that's wasted that could otherwise go to pay for health care, but it's a symptom of a fragmented system. And we have a fragmented system because it serves many, many interests. So I'm not sure that's really the elephant in the living room. I think the elephant in the living room is what Bob was talking about before, that somehow healthcare ought to be a commodity in the marketplace, bought and sold like we buy and sell shoes or cars, and that's somehow the American way.
Rather than the other model you put out, the commonwealth, the well-being of the whole society, what's good for for all of us, a human right.
Well, I agree with that and with Aaron about this. I do think it is the elephant in the living room, though, because of its magnitude. The fact that 30-ish% of the healthcare dollar never gets spent on healthcare, it makes it unsustainable. And it's an immediately controllable factor.
So if somebody says, well, is this really feasible? Is it really feasible to have the kind of system that we're talking about wanting?
Well, the rest of the world, in the industrialized world at least, has figured this out one way or another. They don't all do it the same way, but none of them does it the way we do it. And I think there's a message in that.
Yeah, and nobody is wanting the kind of system that we do, right?
That's what I was saying. Nobody else wants to do it the way we do.
Because you hear, sometimes when you talk with people, and you say, well, in Canada, people like that. And then sometimes people say, well, Canadians don't like their system. But I think from what I've seen, the Canadians do like it. And the problems they've had is that their government they've had some conservative politicians who've underfunded it. And they ration it by waiting lines some. But everybody gets the primary care and everybody gets better care than we get. They get more doctor visits. They get more timely prescriptions, and it's more affordable and costs a lot less, and overall it's greater satisfaction from what I see.
Yeah, I think that's right. All the evidence suggests that Canadians are quite happy with their system.
And you see people from here going there for prescriptions. You don't see Canadians coming here for prescriptions.
There was an issue a few years ago in which there was a nationwide problem in Canada with underfunding, and that resulted in some long waits for certain procedures in certain places. And that situation got worse and worse. And I think what happened is illustrative of the benefits of a publicly accountable system. The federal minister of health called a summit with all of the provincial ministers. They sat down and they worked out an agreement whereby the federal government agreed to put more money into the provincial systems. Now, we have no way of doing that here in the current system. We have ways for the federal government to agree to put more money into Medicaid, but of course Medicaid is only 12% or 15% of the pie in this state. But we have no way, if we say we want more money in the system, we have no way of negotiating that with people who are accountable to the public.
Well, and in Canada, well, in other countries, if everybody's in the same system, then it's affecting everybody. Here with the stratified system and stuff, Congress people get better health care than, a lot of people.
That's one of the virtues of a unified system,
Yeah.
is that it unifies the politics around the system.
Yeah.
That whether you're rich or poor, or whatever categories, Larry mentioned, that you all have the same stake in assuring that there's sufficient resources in the system and that the system's working well.
Your original question, is there a way to do this? I think you asked us, is there a way to do this?
Yeah.
Well, there is. Healthcare for All Washington ran an initiative in the year 2000, and we wrote an explicit bill with statutory language in 20 pages. Now, everybody loves to say, oh, this is too complicated. It's not what we're proposing that's complicated, it's what we're doing now that's complicated.
Yeah.
It's simple in concept to do this. It's a big problem, it's a big issue, it's a lot of money to manage, but it's simple and direct. And the Washington Health Security Trust Bill is the language that we developed in the year 2000. And we introduced that into the legislature this year as Senate Bill 5756 and House Bill 1886, or the other way around.
Yeah.
I'm not sure which number is which. And we did this not because we thought we could get it passed, but because we wanted to show a gold standard against all of the other incremental things that are well-intentioned but don't get us to where we need to be. And people started reading this for the first time in 7 years.
Yeah.
And they said, oh, this is real. This is a real bill. And it makes sense.
Yeah,
and it does these things that you need to have do.
Yeah, I printed out a copy, and I also printed out a copy of just the Bill Digest, which is like it's a 1 or 2 page thing, so you can get a summary out of it from the legislature's website, www.leg.wa.gov. Yeah, and you can go there and print that out. Well, you mentioned Healthcare for All Washington. Tell us just a bit about that organization.
Well, the organization's gone through a number of different name changes. It was called Washington Single Payer Action Network.
That's when I joined it.
And
when
you
it was
joined
WASPAN.
in the years of the last century.
Yes.
In the year 2000, we got brave enough to try an initiative to the people with our concepts. Now, many people, even in the legislature, do not recall 1993 when the state of Washington passed a universal pay-or-play healthcare bill, the first in the country. And it passed after an enormously intensive Washington Healthcare Commission report. 425 pages of careful analysis of what healthcare practices and financing were in this state. And we started with that actual reality of what the reality of healthcare delivery and financing was in that period in the first decade of the 2000s. Our bill is written with the presumptions that what we did then was what people expected to be done. It's an American system, it's not a Canadian system, it's not really American, it's the state of Washington system. It's tailored exactly to what our needs were then.
Yeah.
And it's based on very sound data.
Well, let me put in a plug. We're going to run short on time, but I want to put in a plug for Healthcare for All Washington. They have a website, www.healthcareforallwa.org, and they have a phone in Seattle, 206-323-3393. They also have a toll-free number, 877-903-9723. And I've belonged since sometime in the 90s, and it's important that we, ordinary people, get out there and work on this. When I read through about what the legislation that came along for the 2000 legislature was doing, it did some really good things. It established a specific agency to focus on this, so it would do it right. It was going to have an elected commissioner from each congressional district, so there's accountability to the people. I don't get to elect who's in charge of my insurance company, but I do get to elect who's in charge of this, if this were to pass. It's comprehensive. It has a dedicated funding stream, and it just really seemed like a very smart thing. And you've got a Washington Health Security Trust. Let's see. No, what's the name of your coalition? You got a coalition. That was for the legislation. You got a coalition that involves Healthcare for All Washington and some other groups.
There was an ad hoc group of people that injected energy into the Healthcare for All Washington Health Security Trust. And Physicians for National Health program, Western Washington, were the main motivators for that.
That's right, Washington Health Security Coalition.
And since we were presenting this to keep the idea of single payer, if you want to call it, or unified public financing on the table when we're talking about the connector and all the incremental changes. We wanted to keep our proposal there to show that these other good ideas aren't as good as ours.
They address some part of it, but the plan that you're looking at really does.
Well, and a lot of people in this legislative system came out of the woodwork and started supporting this, much more than we expected. And so based on those people that came forward, we are forming the Washington Health Security Coalition with a broader view than just our bill.
That's good. Yeah, because it's got to come from the grassroots. It's got to be broad because everybody has a stake in it, like you've been saying. And
we're aiming to get 100,000 people to support this idea over the next year, to present some political muscle and some support for legislators to believe that people really want this.
Well, and there are some resources. You've got information posted on the website for Healthcare for All?
Yeah, I have a healthcare presentation posted on the Healthcare for All
Washington
website.
Yeah. If it's just healthcareforall.org, that's the California one.
Yeah,
And ours
you're
is
absolutely
Healthcare for All
right. Washington.
And I read both. The California one's interesting too, but yours is on the Washington one.
That's right. And so you can go to Healthcare for All Washington website and view the presentation. There's a lot of information on there. And the one thing that I think Bob touched on was we need a lot of support from voters on this issue, because if we don't change this soon, we're going to find ourselves in a spot where we're so desperate we'll just try anything. So we're trying to educate the public as well on what is needed in a good healthcare system.
Yeah, and some of the criteria that we've been emphasizing before we close, we're just about ready to close, universal, it needs to cover everybody, all Washingtonians, and ultimately everybody in the country, but the states seem to be how our system seems to experiment, was states try things, and then things try out then at the national. So it needs to be universal, cover all the whole population. one payer, so it runs through public funding instead of all this mix of all the different insurance companies. Portable, so it goes with you no matter whether you're working at this place, that place, not working, divorced, married, whatever age, whatever. Choice of your healthcare providers. I mean, there are a number of just important criteria. I wonder if we could get a closing thought from each of you, and then we'll wrap it up.
Well, Glenn, I think you wrapped up the Healthcare for All Washington picture enough. I'd like to advocate another website, Physicians for a National Health Program, Western Washington. Ask Google to find that for you. Dr. David McClanahan is operating that website, and he's able to keep it updated and includes many of the things we would like to have on our Healthcare for All Washington site also. So I'd like to have people Google that and look at it.
Or they could contact me, and because I've got the name of that organization in my notes.
Good.
So we'll get people connected.
Well,
Aaron.
Glenn, I appreciate you putting on this show. I think it's really important for people in this area and across the state to understand and help to change the discussion about healthcare so that we can get beyond the parochial notions of how can we make more money on the healthcare system and get back to a system that's really focused on how it can best serve people and the providers who serve them.
Okay, thanks, Larry.
Yeah, in summary, I'm going to say that if we reform the healthcare system, what we need to install is security. We need to make sure that the program is fair for everyone. We need to have a healthcare system that's going to provide economic opportunity for everyone. And we need to have a system that puts back trust between the patient and the doctor. And the last thing, it has to be simple.
Great. Well, thanks. I appreciate it all. We're really out of time. I want to thank Dr. Robert Fithian and Aaron Katz and Larry Kalb. I want to thank all the folks who are watching. We have serious problems with the current health system, but it can be fixed. We've got a lot of good ideas, and there's good information out there. I encourage people to get involved in however you can. You can contact Healthcare for All Washington at the references we've been giving throughout the program. For information about a variety of issues that relate to peace, social justice, and nonviolence, you can contact the Olympia Fellowship of Reconciliation at 360-491-9093 or visit our website, www.olyfor.org. We're all one human family. We all share one planet. We can create a better world, but we all have to work at it. And the world needs what you have to offer. Thanks.